today's event, I just wanted to give a brief summary to you all about what BRIDGE is and what it's all about. So the BRIDGE Paediatrics Research Forum started to run this year and aims to bridge the gap in postgraduate paediatric doctors in training's access to research, to be a central hub to signpost trainees to available opportunities and research contacts in the deanery, according to what their special interests are. And to provide educational opportunities for the development of research skills. And so we're going to put out some events, including journal clubs with discussion about emerging research, and that plans to run every 2 months. And events such as the one today, which looks at different aspects of research and research skill development. And finally want to just provide some support and a platform for kind of multi-centre research and quality improvement projects that may want to run across the deanery. So watch this space. So we really hope that you enjoy the opportunities that this programme offers and really welcome any feedbacks and suggestions that you guys have. We want to make sure that this delivers to you what you need. So your voice is really important to us to help shape what we deliver. So to welcome to our first event, which is with Professor Bob Phillips, who many of you will already know very well. But for those of you who don't, Bob is a paediatric oncologist in Leeds Children's Hospital and a senior lecturer in paediatric oncology at Hull York Medical School. He's also a senior clinical honorary consultant at the Centre for Reviews and Dissemination in York, and therefore has a lot of expertise in systematic review methodology, including the more complex analysis such as individual participant data meta-analysis. He's the director of the Candlelight of Supportive Care Research Centre, which opened in, I think, November 2023, which supports work on the development of supportive care with children with cancer. And he's the lead of the PICNIC, so Predicting Infectious Complications in Children with Cancer, which brings together clinical and research method experts and healthcare researchers across lots of different countries, as well as, and that's relevant today, the parent representatives, which looked at patterns of risk in febrile neutropenia. So all in all, a quite knowledgeable person in lots of areas of research, and today he's going to tell us about patient and public involvement in research, which is really important, but also quite a challenging aspect of research. So we look forward to what you have to tell us today. And on that note, I'll hand you over to the floor.
Thank you very much. A lovely introduction.
I hope it's all correct.
What do you want to know today? What have you turned up with a burning desire to know? Throw it in the chat, because it's great to come along to these things and sit there for an hour or so and go, hey, it's like Netflix, but the production quality's lower, and drop off halfway through it. And if that's what it is, if it's a meditative hour for you, then that's fine. It can go on the portfolio as such. But if you want to know something about public patient involvement, family involvement, what burning questions about that sort of PPI, then stick it in the chat and we'll see if we can address some of that going forwards. It's really good, actually, to be invited to be at the start of this sort of thing, rather than it being, oh crikey, we don't want neonates in here. Be at the start of this sort of research thing, rather than being tacked on at the end. Because I'm still looking at that chat. It's not gone to a red bubble yet. No one's put out in, which gives me free rein to just talk about the things that I want to talk about. Rather than being the fluffy extra that goes on after you've thought about what the real research is, and then you put the PPI on it, because that's how it started quite a while ago. It started with patient public involvement being something that was very tacked on in order to make your grant look a bit better, and because some funders forced you to do it. And so And so why should we do it and actually take it the other way around? Why should it be the very start of what we're doing? And I think for many of us doing clinically sort of research, the sort of stuff that involves patients or is very close to patients, it's relatively obvious why that might be. The benefits of patient public involvement are that you can use it to direct the questions that you're asking. Which of these many research priorities that are out there, which of them should we pick up first? If we're doing a piece of research, is it actually asking a question that's of importance to young people and their families? And if it's an important thing, what exactly are the bits in it that are the really important things about that situation that would be meaningful to know whether we've improved the situation or made it worse? Is it a number on a test, or is it an experience? What is it there? Those are the sorts of things that should drive us into looking at an area in order to research it. And there's loads of different ways that you can involve patients in research, and you can start at that very beginning. Which bits should we be doing research in? I will get back to a definition of it ish, but what I'm going to do is tell you about an example of it in a relatively majory way, and then work to a sort of definition. It isn't quite looking at it. I'm going to just throw some slides up, which is, I know, an unusual occurrence for me, but I have actually got some that might be really actually quite useful. So I'm not sure how many of you will have heard of the James Lind Alliance and the priority setting partnerships. Possibly most of you are aware of this sort of unit and gang, the JLA PSPs, and they have a particular method and methodology. The idea behind them was that their researchers in a field would often go off and do research on things that they felt were important. And the peer reviews of those research were their peers, who also felt that the things that they did were important. And that funders were influenced by this cabal, this inner circle of people, and carried on funding the things that they were doing. And it was noticed first in grown-up rheumatology that what the clinicians felt were the important questions and what the researchers felt were the important questions, what the patients felt were the important questions, were not very overlapping. And what the patients thought were the important outcome to measures was different than those that the clinicians were measuring, and different again than those that the scientists wanted to measure. And it was striking, this difference. There was at that point, I think, quite a sensible decision that it might be worth seeing if we could come to some form of consensus, or at least include all these views when we were thinking about outcomes and priorities and going forwards. That there isn't really a primacy of one over another. The clinicians' views are not secondary to those of the patients. The patients' views aren't secondary to those of the clinicians. The researchers' views certainly don't override anybody's. But they all come at it from a different way, and all probably have different elements that are important to bring in. And so the James Lind Alliance set up a methodology that could be used in order to work out what areas needed some research doing, using this idea of sort of building, if not an entire consensus, then at least pulling the bits together. The idea being that what you do in this is you look for the gaps in the evidence rather than looking for the things that have already been researched excessively. How does the method work? Well, it's one way of doing it. It isn't absolutely certainly the best way of doing it, but it will work given enough time and effort. And the one that we first did was in teenage young adult cancer. Now, what you do is you set up an area. You say, what is this all about? What's the limits of the questions that we're going to be asking within this PSP? You have a steering committee. The steering committee includes those who are experts in the process, those who are clinicians in the field, those who are actively engaged in researching in the field, and people with the condition. And in this setting, it was young people who had or had cancers, leukemias, lymphomas, had been through transplant. So that was the gang that set it up in the first place, and came to a conclusion that in this PSP we would include anything to do with TYA cancer as defined from 13 up to the age of 25, using a UK definition. Anything that was in there from diagnosis through to long-term follow-up for survivors, or palliative care and immediate bereavement care for those who didn't survive. All of that was available for the questions to be potentially within that. It wouldn't include questions of how to fund or influence or politically maneuver. It could include some elements of service provision. So in the sense of, is it better to have your chemotherapy delivered at home versus in hospital? That would be an okay question. But how should we set up the entirety of radiotherapy across the UK would sort of be out of scope. That was the idea of the scope of the PSP. That puts boundaries on it. It says that people who want to ask questions outside of this are being excluded. Yeah, that's because you can't do everything all at once, and you have to put boundaries around nearly everything you do in existence. And how you fix those boundaries can be fair and unfair in the way that they're done. This was done through a process of thinking through what is manageable, what resource did we have to do, and what was being agreed with by the people that were in there, that had volunteered to come part of this collaborative. Now, how do we get those people at that stage? We went out and used a wide range of charities who were funding it, but also had large networks of people going out there. We didn't, for the young people, demand that they stay part of it through the whole 2.5 year to 3.5 year process, which was expected, but instead to give us what time they could, and that replacement of those young people as the process went on was expected, so that no one felt that they would be letting us down by taking part in it. We monitored who was on the steering panel and tried to make sure that we had as broad a representation as possible. And I'll talk about the things that we missed and couldn't get in a second. And with that broad scope, we undertook the process. The process going out into the world and asking people, have you got any questions? Well, it turns out that people have a lot of questions, and they submitted them. They submitted over 855 that were actual questions, and that's dropping out things that were like, why did I get cancer? Why did so-and-so take so long to get diagnosed? Shouldn't there be more money in children's research? That sort of thing. 855 potential areas for questions. Of those, 16 of them were under active study in a large clinical trial or other sort of big style thing, not little pilot studies, but proper big style ones. And only 7 of those potential questions actually already had answers. Now that's striking, because we just said, what questions have you got? Not, can you just go and check to see if there's an answer for it first before you put it in? Nearly everything that people put in, clinicians, researchers, and the patient, the public, and their relatives, was an unanswered question. So that had an awful lot of things that were still there. And so we went through and took out of those 185 from those individual questions that came into sort of question categories. These then came down into probably 121 really, because you could say that those two were basically the same sort of question, so you could squish them together. And then how could we get people to rank within that, which were the most important to deal with? Not losing any, but which were the most important to deal with. And so ideas of it being questions that had been asked by more than one person, or different types of questions, but put into that same category by more than one person, 64 of those. And then there were a further 40 or so where, although they might have only been asked by one person, were felt to have a degree of greater importance that might have been lost if dropped elsewhere. So there might have been, in fact, this one there was a question about sexual functioning after treatment, and it's something that isn't talked about in children's, and not really talked about by doctors and researchers often in young adults, whereas young adults will talk about that amongst themselves. But then how does health play into that? So that sort of question that was striking got on further, and then these were then ranked. They went out into the public again, and they had the choice to rank as many as they wanted, as the highest and the lowest priority. At the time, the James Lind Alliance felt that it was unfair to ask the public to do this for more than about 20 questions, but we had an awful lot of people come back and give us their views on it. Around about a third of the report, the sort of the priority setting rankings that we got back were from young people. About a quarter of them were parents. These self-identified as young people and parents, and the rest, around about 40%, were from medical healthcare and healthcare research staff. And that gave us a relatively clear top 30. We had sort of rankings of each of the individual ones, and then it sort of tumbled off after it got to about 30. And then these were taken to an in-person event where the different people again were invited to come along, again a mixture of patients, their families, healthcare professionals, and active researchers in the field. And these were then prioritized over the course of discussions, in-person discussions over the course of that day, to come up with a top 10. This top 10 are not research questions in the sense of you can't do a trial on them, but they are research priorities. They are areas to work on. What about getting better targeted treatments? How do we follow up with psychological issues? How do you get on and support people post-bereavement? How do you get people back in work again? What about the way that we support people when they're not smack bang in a TCT centre? Is there anything that we know about palliative care in young people that is separate than in grown-ups? Can GPs diagnose cancers faster? If we're going to make things better through clinical trials, how do we make them more accessible? Can we please do some work on side effects? Yes, we can. We know supported care priority centre. And then first and foremost, above everything else, how do I stop feeling so rubbish when we are going through all of this? Was that always going to be the way? No, it wasn't. When we started this, we sort of scrolled down on a bit of paper, a few of us that do it, what we thought would be in that top 10. Bereavement support absolutely wasn't. Nope, was nowhere near the list that we came up with, and we thought that it was almost a bit of a waste of time and money, because the way that children's and young people's oncology works is very much collaborative with the patients. The researchers are the same people as the doctors. I mean, it's not even really that separate, is it? So really, should we be doing this? Is it a bit of a waste of time? No. Stuff came up there that was different, that was new. We don't know until we ask. And then you stick them up there and you go, well, yeah, of course those are important. Of course those are obvious. Yeah, that's sort of all the way with qualitative research as well. It is important to do because it makes a massive difference. Now, that sets up the priorities that can then be researched in that area of medicine. To take any one of those and turn it into an actual research project, though, requires even more input and advice, because you can't just take one of those and do a study on it. They just don't work that way. So each one then requires further thinking about as to what research study needs to arise, or which of the research studies, there might be many of them, that can arise from each of those priorities. It shall be taken forwards first. And that is, again, going to be an idea of consensus collaboration and bargaining. What is it that I have the resource, maybe access to money, maybe skills, maybe collaborations in order to do? Which of these elements are considered the higher priority within it by patients and their families? Which have I got skills to access in order to take them forward? And then when you've got that area, how do we build this study? How do we do it so that it's practical and useful, and people will actually take part in it and fill in things, or will turn up for things? Because whilst we've got these brilliant ideas, how can we make it better for young people to take part in it? So Jen Preston's works at Alder Hey in Liverpool, and she's one of the first people who really started working on how do you get young people in particular, not just their families, but young people involved in research. Went out and started doing some negotiations with pharma companies, not academics, pharma companies, as they were doing their research, to say, why don't you, the pharma company, actively engage patients at the point where you're putting the studies together, rather than just trying to get them to take part in your studies? A lot of resistance. This is very intellectual stuff. It's far too clever for young people. They won't get it. There's so many regulations that they won't be able to follow. It's a waste of time. Eventually, there was a little bit of crumbling, and one of the companies said, all right, and started to engage with a set of young people. Took along their nearly finished protocol for, I think it was an asthma drug or a rheumatology drug. One of the at the time was new biologics coming through. And they wanted to do a whole load of things, testing function, assuming immunity, all getting people in for assessments, all that sort of stuff. And the young people were like, yeah, but we're already coming into clinic, X number of times. So why are we doing that in between? Why can't we just put those in the clinic visit? And if you want us to come for any extras, then why are you doing it during the daytime if all that stuff could be done after school and things? Because then we could actually go to school and come along afterwards. And do you really need to see us every week? Why can't we just phone up? I mean, that's what we do all the time anyway. And they took this protocol apart and said, which are the actual important things that are in here? Which are the things that you're stressing about that aren't actually necessary? And the revised protocol probably saved, I think Jen says, £500,000 over the course of the study, and got through the various regulatory procedures, the company felt, faster, because it had engagement, and because it was already proven to be something that was useful and interesting. And that started then a bit of a worldwide move to pharma companies, some of them having PPI departments. Amgen has gone on, along with others, including Begonia and Friedi in Barcelona, to start doing research on research and pushing that forwards, so that now we have a better understanding of the better ways of doing PPI when it includes running, collaborating, bringing on projects, and then a little bit on the far side, disseminating information in a way that's meaningful to patients, public, and their families. We haven't got Jen Preston, we haven't got Alder Hay here in Humber and Yorkshire, but what we have got running out of Leeds is a similar sort of thing. So Jen started the Generation R, Gen R research groups. And there's one that runs out of Leeds, I think called LYRO now, LYRO, Leeds Young Research Owls, I think was the name of it to start with, by Heather Ostrom. And that runs on an approximately monthly basis in an evening. That has the opportunity for young people, a variety of young people, to come forward over the internets and to take part in a group that lasts around about 2 hours. It has a little bit of education about research in it, and it has the opportunity for researchers to present their ideas to the group at various levels and asking for various things. So it's a way of accessing PPI to develop, to fine tune, to understand your ideas, or the way that you're describing your ideas, and get feedback on it so that you can make your research study a little bit better. This group is a generic group, so it's a bunch of young people, the majority of whom have a form of chronic health condition, but not all of them. And they drop in and out, but there's a sort of a group that will flow forwards. And I think they talk about being in that group for a couple of years on average, and then leaving and moving on. That's good if you want the involvement of patients and people who have an understanding of what healthcare is like to them, and will have had contact largely with others that have also had sort of ill health type things done to them. But it isn't particularly good if you're looking for specific sorts of information about the aspects of what it's like having acute lymphoblastic leukemia maintenance running for 2 years and having to go to school and high school with it. If you're looking for something very specific like that, then you could do the checkbox exercise of going to a group like that. You could say, yes, I've got PPI involvement. Yes, these young people have told me these things, but you really don't think you want that. I think what you want is more specific input, because this is not about the checkbox. This is about understanding from what people say and do, and making a meaningful difference. And that then means finding a specific group that you can do that with. In Peds Oncology, Candlelighters, the charity that set up the Sport Care Centre and so on, they've got a PPI group that meets and has young people and has families that you can take your ideas to, and you also have a group of people that are happy to have sort of email type contact with them back and forth as well, in order to not just wait for the single meeting occurring. But you can have groups like that. There may be other groups that exist. There may be a national patient support organisation for people with osteogenesis imperfecta, I'm imagining. And that might be a great location to go to say, okay, we want to do yet another study in OI looking at this. What can we do to make this study better? What worked well, what doesn't work well? What are the important things that we need to bring into this? This is what we're doing. This is what we're worrying about. It might be that there isn't even that, and you need to get out there and get something bespoke. And that's another thing that we've had to do over time, where we've had research studies where there hasn't been something really obvious out there in order to leap to. And we've gone a bit like the JLA PSP via social media to say, who wants to take part? Who do you know? Who wants to volunteer themselves? Which then comes to this this problem that is perceived that PPI is from a particular group of people. Now, the problem of patients who continually take part in the PPI exercise being of a very particular demographic is a real issue, very strongly a real issue in the setting of adult medicine, potentially a little less so, not entirely less, a little less so in pediatrics. Looking at many of those who are the patient advocates and champions that get seen and get drawn through things time and time again. They're frequently cisgender men, they're frequently white, they're frequently university or higher university educated, and they've often had a professional career and are retired when they get round to doing their PPI. Do they represent the voice of patients across the world with all that condition? No. PPI isn't representative though, that's the first thing. It's not meant to be representative. It isn't a generalized field. This is not the same as quantitative research. But it is a problem if that's the only voices you're hearing. And so, like in all areas of research, we should be trying to address those areas of our ill population that are underserved in our patient and public involvement groups. Back to the JLA PSP. When you look at teenage young adult cancer, the people that get teenage young adult cancer, more or less, when you lump them all together, are pretty similar to the population of the UK. There isn't massive spikes in any one particular demographic group or another. Varies a bit between cancers, but when you sort of bung it all together, it all comes out roughly the same. Looking at what we got back from the survey, because we asked people to say, what are your demographic characteristics? We didn't ask them that question. We asked them it split down into bits that were easier to understand. We found we had an excess of females putting back any answers, and we had very, very few people who did not identify as men or women. So we were underserving there. When we looked across the ethnicities that people said, we had too many white people giving answers to these questions. And we had too many people that were educated to A-level or higher in comparison than what you'd get from the general population. That was our survey data. When we went out to get people for the workshop, there was specific approaches to make it more even to what we were out there. So there's a group called Black in Cancer, which is set up and run out of London, but is a national organisation that aims to improve the voices of Black people who have had cancer and are engaged with cancer services within the development of services, but also within the development of research. We went out via Stonewall to see if we could use their youth network to improve the chances of getting queer youth to come along as well. So we know that generally speaking, if you're queer, genderqueer, or sexuality that isn't straight, you don't have as great an experience of healthcare than if you are a straight cisgendered person. We went out through there again, seeking extra input from people that weren't being served by our usual and standard ways of doing things. We didn't get the exact evenness and representation of the population. I don't think that we almost ever will, because in things like this, we will find it very difficult using these sorts of techniques to include those people who have had a significant brain injury following a brain tumor, for example. The way of engaging folks with that situation is going to be different than it is that if you haven't had a brain injury, by having a neurosurgeon pop their hands in your head and then irradiate it afterwards. And so you've got to take these things with a pinch of salt. And that's a little bit where that idea of not having a primacy of one group comes in. And it is about using patient-public involvement alongside using clinical expertise and using the researcher's expertise to bring these things together and examining it that's coming back. Are you hearing the same things repeatedly? Are you hearing the same voice saying one thing and other voices are not being heard? Who haven't we got in the room, and what are we understanding by that missing? None of this is going to be perfect, but it's going to be better than not trying in the first place and just deciding for people. And getting somewhere is better, I think, than waiting until we get it perfect. Now, what else can we produce? Well, you can also get PPI, after I've told you all these wonderful things, to help you with your recruitment. So there's a recruitment video, I think.
And I am here to tell you about research studies that is going on at Leeds Children's Hospital. When you are having chemotherapy and you might get poorly and feel really hot or unwell, if that happens, your mum and dad will have to ring up the hospital. You'll need to go to hospital in case you have any bad infections. At hospital, the nurses and doctors will see you. They will always do blood tests and give you antibiotics in your line. You need to stay in hospital and have antibiotics until everything has got better, and then you can go home again. The research is to see if a special blood test that the nurses could take will help them to tell who is really poorly and who just has a cold and could go home sooner. If you and your mum and dad agree to take part, if you come into hospital with a temperature, then we will take an extra tube of blood. The scientists in the lab will then do the special test on the extra blood. Later, we will tell all the other doctors about this in meetings and by writing an article which is like the news for doctors and nurses. You can ask your mum or dad or the doctors or nurses questions about the study, and you don't have to take part. Thank you for watching, and remember to like us if you liked it.
Doing things like recruitment videos with young people massively increases the number of people who want to take part in your study. There's only one study that I've ever actually been approached by small children on the corridors to ask if they can be part of, because they've seen that one of their friends is part of the Lego study and on their beads of courage has got a Lego head. And the way that they get that Lego head is by asking me if they can be part of the study. And so can they be part of the Lego study, please? And this was generating stuff, and parents were talking about it to other parents. And then the parents were going, "Can you know that thing about infections? Can we be part of that as well?" It was remarkable. I mean, partly it's because of the nature of the study. So it was getting you out of hospital quicker. And after about the first episode in, nearly everybody wants to leave hospital faster. So there's something about that. But there's something about using young people. And I say that in a caring and sharing sort of way, rather than a beating them with a stick way. But that resource and engaging with people in a way that is meaningful to them to drive things forward. And so you can get great advantages from your study by the patients, the public, and the family members taking part in it and helping you put that study forward, even while it's ongoing. There's a methodology, a quintet methodology, where you look at actively recruiting studies, you look at the numbers involved, you look at how consents are being done, you ask people that have said no, what was it that made you decline this study? You don't ask it as coarsely as that. And you use that information to understand, are we putting across this study badly? Are we trying to describe this badly? Patients inputting into the running of a study so that it can be made better and driven forwards. There are, in the committees that sit on clinical trials, the steering committee and the management group, not so much the data monitoring committee, which is a slightly different. There is patient and public family type involvement in nearly everyone that's going forwards, because that input about how this works in the first place is also useful as you're going through a study, and then patients can happily put in their information on the far end in order to tell you just how badly you've written that lay summary, why it makes no sense, and how it'd be much better if they did it first. And for quite a number of years now, when we've done presentations on studies, we've asked if a member of the patient involvement group would like to come along and present either with us or instead of us, or do a video about it, and do that when we've put forward the study and its results at the sort of conclusions of what's gone on. Is this a gimmick? No, it isn't. It helps the audience understand the meaning of what you're doing in a different way, particularly with clinical studies, and take this forward and take this on. Can they be involved in any other steps of the studies? Yeah, actually. It's been done, not by me, because I think young people don't need this boredom in their lives, but with systematic reviews, you go through the papers to say what's in and what's out. You do screening exercises. It's been done, that there are training packages out there that people can volunteer to take part in doing that. They don't have to be researchers as such in order to do that. And so that's been a thing that patients have been involved with. Simon Pinney, a choral at the University of Leeds, has had young people taking part in the thematic part of the analysis of a qualitative study to do with young people and their who have chronic disease and their engagement in education, where young people came in and also supported the qualitative researchers in looking at encoding, in doing thematic work with the data in its fully anonymized form, not in the raw listening to the transcript stuff, but again, putting a different view in and adding more as you go along. What skills do you need in order to do that? Is a question that's being drawn out there. Well, you need the opportunity. You absolutely need the opportunity. You need to be able to get at that group. You need to have the resource. You need the funding, and you need some skills yourself. Many of those skills as paediatricians you will have. The ability to talk to young people in a way that is meaningful. The ability to have tripartite conversations, including parents, alongside young people. The CRB checks are equivalent in order to be allowed to do all of that stuff. You probably need to up your facilitation rather than consultation skills. This isn't about drawing information out of them. This is about encouraging them to engage and share that information and have a dialogue with them. And there are now 1.5 courses on PPI in children and young people. One runs every couple of years, compared to the you can probably find one every week when it comes to PPI in grown-ups. Is there a benefit of going to a PPI in grown-ups training session if you really want to get into this? Probably, in the grown-ups are just big children after all, so there are some things in similar, and there's a little bit of going along to find out what it's like for them, and take some of those ideas away, and then to correct them and think where they're not right and where it might be better to use different approaches. One thing that's sort of in there, in the chat, and throw in any extra questions, I'll shut up in a minute for more straightforward questions, is sort of qualitative research versus patient public involvement, and there's a blurring, and there certainly was a very strong blurring in the past that led to all sorts of people scratching their heads because they want a really clear difference between the two. Qualitative research is researchers have a group of skills using a group of techniques in order to get some outputs. Some of those skills will be useful when you're thinking about the inputs from PPI. Some of the quantitative ones will be as well, like counting how many people are there. That's quantitative research, but it's not really drawn out that way. So there are some of the skills that are used, but the meaning of it is quite different. Research is, on the whole, about finding out new things that will have use beyond the immediate situation. The difference between research and service development. Service development being, in my hospital, how do we make this better? Research being, can we take these principles and then say something about making things better more generally? It's not an incredibly clear difference, but that's usually the one that's sort of used by Rex and the like. And it's the same sort of idea with PPI. Patient public involvement in research is about what are the priorities in this area. When we're thinking about this study, what are the things that we should be doing? When we're thinking about this study that's running, what are the inputs that will make it better or worse? They're very specific, and they're very to do with the one area. They are not using those people and getting the research findings out of them. Slight aside to that is, you often write up what's happened and what's been done in the PPI and get it published as a paper, often alongside the PPI doing that writing, because there's so little still out there that describes how PPI works and whether it was good and whether it was bad and stuff like that, that you actually do need to get it out there just in a descriptive sort of way. So that's a slight fuzziness about it. And then when you get on to co-created stuff, that becomes a right mess. But we'll leave that to another day. So, right, I'm going to shut up there because I think I've done the run through most stuff, picking up some of those issues as we've gone along. What else do you need to ask via the chat or not via words? How do we find studies where we can volunteer to do some PPI? Right, so if you have a health condition and you want to be part of the patient public involvement as a person with a health condition, get on and get onto the charities related to whatever that condition is or isn't, would be the way forward. If you want to help the PPI being done for a study, that's sort of more the other way round, where you really need to find somebody that's doing a study and then saying, I've got the skills to be able to help this PPI stuff go forward. Can I help bring this on a bit? Which is one of the tricky things. And I'm sure you'll have another event about how to get research opportunities up and off the ground in the first place. It might be that seeing if you can go along to the LIRO or to one of the other events like that where PPI is occurring, and just observing how it's happening. In a way, that'll be a good start on that and get you a feel for how it works. And it might be that you get dragged in relatively soon in order to do a little educational talk on something to do with research in a way that can help the young people understand it maybe in a bit more detail. bearing in mind that GCSE now does phase 1, 2, 3 studies as part of the core content of most of those GCSEs. They know far more than they did many years ago when I were doing GCSEs, I tell you. Anything else wanted to come through there?
I think there were some previous questions as well.
Yeah,
just
so
for them up on the chart.
Yeah, I think we've sort of touched on the representation and balancing, Lyro, other areas. Cool. I've talked a lot from the applied health research side. It absolutely is possible to do within lab-based stuff as well, and there are lots and lots of examples around the country where people have done things with brain labs, with neuropsychological studies, with drugs, not naughty ones, pharmaceutical type things in development. So my experience is within the applied end, but it isn't just applied that it goes to. It can be at most stages. I just needs input. Excellent. That looks like enough then.
Wonderful. I'll give people a couple of minutes if there's any other questions. But in the meantime, thank you very much, Bob. That was a really interesting talk and really informative as to kind of like how you managed to use PPI in your research and the opportunities that it gives us. Oh, there's lots of thanks coming in from that. Just as an aside question, in terms of with the BRIDGE research, kind of like what kind of opportunities can you offer for people in our region to get involved with research? Is there anything kind of like out there that you think actually someone could contact you to and you could provide them with some way of kind of like getting a foot into research or being involved, or is there anything that you wanted to advertise?
I'm deeply uncollaborative and harsh. Don't even try. No. I haven't. Right at this very moment, I haven't got anything that that pre-work would be warranted. But we do have a bunch of stuff coming through, hopefully soon, where we will be looking for volunteers, or potentially if you want to get involved. But we're just closing up the. It's a priority setting survey, but it's a very specific priority setting survey. So which of these areas are we going to do next, and that will then generate need for the potential for input going forwards. If you've got ideas of stuff you want to do that is peds oncology in supportive care, then feel free to drop us an email. I will try and palm it off on somebody else.
Brilliant, thank you. Right, I'm just going to share the last set of slides, which just has some feedback forms and everything on it. So not that one. Brilliant. So we really hope that you all enjoyed our first session. I thought it was terrific and really interesting. And there'll be a feedback form that we've put on the next slide with a QR code that will hopefully link you to getting an attendance certificate for your portfolio, which is very important. And as I said earlier, we are really welcoming any feedback and suggestions about what you want this programme to deliver. We want to make sure that it meets what you need, and we are really happy to shape it to what our trainees in the region need. So we want to hear your voice, and it's really important to us. As for our next planned events, we'll be hosting a journal club in April, and we'll announce the date and time shortly. We're just in the final stages of planning that. So look out for that in your emails. And on the 16th of May, Kath Johnson is introducing us to the COMET study. So we'll be really looking forward to hearing about that. So join us at 2 o'clock on Teams, and you'll be hearing from us through your emails. So this is our lovely feedback form. This is the QR code and also the link to our feedback form, and we'd be very happy to hear your feedback. And if anybody has any other questions to us at this stage, then you're also welcome to just pop those into the chat or just unmute yourselves.
All right, Diane. Can I talk shop for a minute?
Yeah, sure.
I was just wondering about the website. Sorry, I missed the first meeting. I saw what was put about how it would be suboptimal to be part of anything that needs a password login to access and things. And there was mention of someone was getting back to us about how it could, what platform it could live on. I just wondered if there was, did you know anything else about that? What was being floated as possible platforms to use?
So the training rep meeting is yet to happen. I brought it up at the school board meeting on Friday, and the outcome was that they would take it forward to the training rep meeting and just see what they can do in terms of platform. Our landing page cannot take any extra thing because it's outdated, and the rest of the websites would need you to be registered on SharePoint, which is not ideal for people who are not enrolled with the School of Pediatrics. So I think at the moment, going forward, we'll try our hands on Twitter as well, see if we can advertise there while waiting for the school to sort out sort of a website for us. So yeah.
So by the landing page, do you mean the Yorkshire and Humber Pediatrics NHS UK page?
Yeah.
Interesting, yeah, because I spoke about that a few years ago, and they did say that they could just give us an extra tab, but that's different now, is it? That's full up according to them.
Yeah. So, but it would have, I think that's what other people are doing in other regions, because if you go to Training Research Network, you can just link up to West Midlands or anywhere just by clicking on their link on LCPCH page.
Oh, the Trainee Research Network, RCPCH.
Yeah, so you can see all the other trainee research networks in the regions, and just by clicking on it, you can be able to. Yeah,
Okay. So that's the target, is it, that we have something that we can link from there?
Yeah, that's the plan. So people know, like if someone is just thinking about research in Yorkshire and Humber and they don't have an email, they know where to go to. I really like the one for the Northern Ireland because it's also a place for them to advertise upcoming events. So that means people can actually know what you've planned and you don't have to rely on sending out emails to people to advertise events. But till that happens, we'll just try and create a page on Twitter and hope we can get people to check there. Yeah.
But we can't. How does the mailing list work? Everything has to go out via the Blackboard.
Yeah, and some people are not on Blackboard. The people who are in Yorkshire and Humber but are not trainees, they don't get Blackboard emails. So we then have to rely on people sharing it within their local hospital groups for everybody to know about this. So it's not a very effective way of advertising the meeting.
I was just wondering about foundation doctors as well, because they often want to get involved in stuff for their applications. Or
I sent out an email that is meant to go to all the TPDs and college tutors advertising Bridge to them and just saying to them, you can email us if you have any inquiries. So I'm hoping, the problem with this is I have no way of knowing if it's gone out because it's meant to go from the pediatric support group. But I'm hoping that then if there are foundation year doctors wanting to know a little bit more about research, they can be able to direct them back to us and just say, we've got this person asking questions. Yeah.
Did anyone reply to you on that to say they would send it out? Or
Yeah, so it was at the school board meeting. I sent it to the admin staff. I sent the email straight up to her while I was at that meeting. But it's now, I probably have to chase up with her to say, has this gone out? Alternatively, I can also try and do a second set of email. I should have all the college tutors list for the East Yorkshire, but I don't have that for the South and West. If we have a way of getting this, we can from our email address just send another round of emails to them and say, if you can encourage people to come for this, that will be helpful.
Cool beans. Thanks very much.
Yeah, that's fine. Thank you. Okay, bye now.
See you later.
See you later. Hi.
Hello. You know, the QR code, does it take you to... the link takes you to the feedback page, but the QR code seems to take me to the overall page. Did the QR page just take you to the normal feedback page, or did it take you to the responses? Maybe I'm logged into something on my phone or something, because it keeps taking me to a page where I can see everyone else's responses. So I might be
I think probably you're logged into the Gmail.
Yeah, that's okay. I was just checking that like everyone else wasn't.
Yeah, because I've just submitted
given a link to our Gmail drive because it just kept sending me there. That's fine.
That's okay.
I think that worked quite well.
Yeah, I think so. I don't know if Ahmed is still on here. He was asking for the link.
For the feedback link. Oh, yeah.
Yeah.
Yeah, that's sorted now. I've just completed
brilliant.
it. Thank you very much. Thank you.
Brilliant.
Okay, all right.
Thank you for coming.
Okay, thanks. I'm going to run now. I need to go pick up the kids from school. It's about school run time. Take care. Bye.
You do that.
Okay.
See you.
Bye.
Bye.